It is my pleasure today to introduce Dr. Stephani Stancil. She's an associate professor of pediatric clinical pharmacology and is a practicing clinician in adolescent and young adult medicine at Children's Mercy. Her interdisciplinary translational research focuses on precision therapeutics for adolescent mental health and the development of biomarkers of drug response and exposure. Please welcome Dr. Stephani Stancil.
Thank you, Michael. All right, today we're going to talk about a method of imaging that helps us get a sense of how much drug is in a particular compartment that might be hard to access otherwise. I have no conflicts of interest. And we're going to start with what is 19F MRS. Then I'll provide a couple of case examples of research applications, and then hopefully sow some seeds of innovative potential of how we might be able to use this technique in a broader fashion. So taking even a step farther back from 19F MRS, what's MRS? MRS is magnetic resonance spectroscopy. It's an imaging method that helps us detect and quantify chemicals within a particular physical compartment. To a patient, it looks like they're getting an MRI, but we're able to gather data that helps us quantify a particular compound or compounds that we've kind of dialed into. And it really leverages the characteristics of particular atoms within a molecule to detect and quantify. So what atoms are good candidates for MRS? The table that you see here are the most common. And by far the most researched and published on is proton MRS, which is that top one, H1. And it helps to detect neurometabolites in the brain, like GABA, glutamate, glutamine, and so on. And while it has kind of a versatile application, there is substantial biological background to contend with. If you think about an atom or a molecule like water, for example, there's 2 hydrogens for every molecule of water. And as human beings, we are a whole big bag of water, right? And so there is a lot of biological background when you're doing proton MRS that you have to account for, and just adds to challenges in analysis. So there are other methods that can be used, and 19F is one of them. 19F, simply fluorine. Think back to the periodic table. The benefits of fluorine MRS is that if it's fluorine in our biological environment, 100% of that fluorine is 19F. That's in contrast to something like carbon, 13, where only 1% of carbon in our environment is in its 13 form. And so you really have to have a much larger pool to be able to reach a level of detection. Not the case with 19F. The other thing is there's not any biological background, right? So we don't have fluorine in our bodies. The only reason it would be there is if we put it there, if you ingested it or otherwise. So those 2 kind of main characteristics really set up 19F MRS as a promising method for drug detection for clinical pharmacology. The other thing I'll mention is that each one of these atoms essentially has its own chemical signature. If you think about tuning forks of different sizes, when you kind of hit or tap the tuning fork, they resonate at different frequencies that you can hear. Each one of these atoms is essentially excited through kind of the MR process, and then it resonates at a particular frequency that you can tune into and receive and really be able to detect and quantify. So 19F MRS really allows us to detect molecules with fluorine in their molecular structure. And it sets us up to be able to do PK in otherwise inaccessible tissues. Today, we're going to talk about its use primarily in brain. And again, to a patient, it looks very much like they're getting an MRI of the brain, but we are tuning into fluorine-containing medications that they might be taking. How relevant is this? How relevant are fluorine-containing medications for clinical pharmacology? Pretty relevant. Up to 20% of the commercially marketed drugs in the US have fluorine in their molecular structure. From a pharmaceutical development perspective, fluorine is often added to compounds because of its properties that can make it contribute to making it more permeable, among other things. And here's just kind of a short list of common compounds that do have fluorine in their molecular structure. Maybe you recognize one of your favorite drugs up there, maybe not. Today we're going to talk about fluoxetine and pantoprazole. You can see here in these spectra in the figure, the nice tight peaks from each one of these compounds. Fluoxetine is on the left, followed by pantoprazole and lansoprazole. And then you have kind of the reference, the TFE reference, which essentially tells you, yes, you're picking up fluorine like you want to. And then the position of the peak is distinct, as well as often the size and sometimes the shape and the double peaking, as you see with the panto. So let's talk about some advantages and considerations of using this method in a clinical study when wanting to quantify drug in otherwise inaccessible tissues. Some of the benefits are that it's non-invasive. Other ways to get drug concentrations in the CNS often involve things like lumbar punctures, right? Which is hard to do, often unethical, depending on the situation. And so this is a non-invasive alternative. It's also non-destructive. We're not going in and taking a biopsy of the brain and homogenizing it and then, looking at it at concentrations downstream. You essentially get back what you put in, right? Everyone who goes in for a brain MRI comes back out unchanged, which is really important. It's also non-radioactive. We're not radio labeling any chemicals here. It's essentially just leveraging the fluorine that's already within the molecular structure. And it allows us to look at individual level data for PK, and it's a less than minimal risk procedure from a human subject's protection perspective, which makes it a safe option for vulnerable groups like pediatrics and pregnancy. When thinking about whether or not this would fit within your own clinical trial, some things to consider are that if you have a patient population or a patient that would have other contraindications to getting an MRI, they can't get this, of course, right? So all of those MRI contraindications hold true. Those are things like MR incompatible metal in the body that can't be removed. Participant motion and scanner is another consideration. So with any MRI, you really have to hold still. If you've ever had one, you might remember being told, don't move your knee or don't move your head, right? If you're moving a lot, that's going to interfere with the data acquired and potentially alter kind of what you're able to do with that downstream. So we do have to have our patients stay very still. This is possible in pediatrics. We do this, and most of our patients tolerate it very well. For these images, we often have them watch a movie or listen to music while they're getting their scan done. And then coil size is also important. And so with the particular tissue or compartment that you are interested in measuring from, there is a coil that fits around that allows both radio pulses and also receiving of that particular signal. So what you see up here is an example of a head coil. Looks like a baseball helmet. And in fact, you might recognize that part, the insert, and that did start as a baseball helmet. This kind of fits in the patient as they're laying flat, and it needs to fit nice and snug. That also helps reduce motion back and forth, and also optimizes signal to noise during acquisition. When thinking about the compound that might be a good candidate for this type of method, think about the expected concentration of that drug or molecule in the tissue of interest. Right now, the lower limit of sensitivity for MRS is in the micromolar range. And so if you're wanting to detect something that's nanomolar, it's unlikely to be successful. But if you think it's going to get up and get to the tissue within that micromolar range, it may be a good candidate. Other things that may suggest that might be possible is the lipophilicity and the permeability to the tissue of interest. Protein binding seems also to set one up for success in this capacity. Fluoxetine, for example, is highly protein bound, greater than 99%, and that leads to a lot of non-specific protein binding, particularly in the brain, which contributes to accumulation. And so that kind of increases the overall concentration in that compartment and would allow us to potentially detect. Other considerations are the number of fluorines per molecule. What you see up here is fluoxetine. Again, you have these nice 3 fluorines per molecule. There are other medications that might have 2 or 1 fluorine per molecule. The more fluorines, the stronger the signal, kind of theoretically speaking. And then what is the estimated brain to plasma ratio? Is there any data that could help you estimate what that might be and kind of build your confidence that it might reach that micromolar range and be a good candidate for detection? Let's see. Okay, let's talk about two research applications, so case examples of how we've done this in our work. We'll talk about the use of 19F to help us identify target exposure, as well as to work through some CNS off-target effects. So let's start with mental health. That's where the majority of my work focuses on. And we know that anxiety and depression are unfortunately common in youth. Up to 1 in 5 experience a major depressive disorder during their teenage years. And selective serotonin reuptake inhibitors, like fluoxetine, are the first-line pharmacotherapy for these conditions. But some patients respond and not all do, and often it's a little bit of a flip of the coin as to who's going to respond to which medication. And all the while, it takes 4 to 6 weeks, sometimes longer, to really know whether response is present. And wouldn't it be great if we could get that down to days? Well, thinking about precision treatment, that is really the goal, to identify the individual factors that can help us do a better job picking the right drug at the right dose the first time. And identifying target exposure is key for that approach. One way to do this is to measure concentrations of your drug of interest. In this case, it'll be fluoxetine in plasma, right? Draw blood, look at concentrations via mass spectrometer, and lots of groups have done this. They've looked at fluoxetine in many different ways, the primary drug, the metabolite, a combination, and there hasn't really been a clear therapeutic range that has been consistently shown to impact or predict response. What about the brain? It's really difficult historically to look at concentrations in the brain, but we know that's where the drug is working. And so wouldn't it be helpful if we can say, okay, well, what about exposure in the brain? Can we identify target exposure and then work backward from there? And that's where 19F MRS comes into play. And it allows us to answer questions like the relationship between dose and brain concentration, brain and plasma concentration, as well as brain exposure and clinical response. So this is a study that we did both in adolescents and adults. We started first in an adult cohort to optimize methodology, and then we extended it to our adolescents between the ages of 12 and 21. All participants were on fluoxetine at a stable dose for at least 4 weeks to reach steady state. And they had a brain scan, peripheral blood sampling, as well as some clinical questionnaires that they completed. And what we were looking for was fluoxetine in the brain. And you can see this spectrum from one of our participants, a 15-year-old on fluoxetine. And you can see that nice peak here in the middle, representing fluoxetine, and kind of the external reference here that you'll see kind of in all of these spectra going forward. One thing to note is that this peak is not only fluoxetine, it's representing both fluoxetine and the primary metabolite norflu. They both have 3 fluorines per molecule, and they resonate so closely that it's really impossible to separate in a human brain. And so when I talk about fluoxetine in the brain, it's really total fluox plus norflu. So when looking at the relationship between fluoxetine dose and brain concentration, you see data from both adolescents and adults in this graph. And overall, it's a really nice tight relationship between dose and brain concentration. But what I'll draw our attention to is within any given dose category, you see at least a 3-fold variability in brain concentration. The other important factor is if you think about somebody on 30 milligrams, they may have a similar brain concentration to somebody else on 60. This becomes important when thinking about conversations with patients and families, when there may be concern for dose titration to reach clinical response. This is data that helps inform those conversations to say, we really want to get to the dose that's right for you, because we know that there's such variable exposure from the dose perspective alone. We can also look at plasma concentration and brain concentration. Again, this is total fluox plus norflu for both of these comparisons. And you can see a nice tight relationship here as well. But the take-home point from this particular figure is the ratio of brain to plasma. It's between 10 and 50-fold higher in brain than it is in plasma. We can also begin to look at things like what are the patient factors that might contribute to brain disposition. We did this by looking at dose, plasma concentration, age, BMI, and several pharmacogenetic relationships known to impact fluoxetine disposition. ABCB1 is the gene that encodes for PGP, and fluoxetine is a PGP substrate. And through this work, we were able to find that dose, plasma, and these two PGX variants, or kind of genotype predicted phenotype groupings, explained 85% of the variability in brain concentration. I will say that dose and plasma alone explained about 83%, so we don't gain a ton by these two additional PGX factors, but they are there. So that's all great and wonderful. We can understand the individual factors that can contribute to variability in brain disposition. We can do the same thing with plasma concentrations, and I know folks in this room do this often. But what does it matter if it doesn't tell us anything about response, right? And so we wanted to look at fluoxetine exposure and response, both in plasma, but now also in brain. And these the data that you see here are just from the adolescent cohort, so there's 48 adolescents represented, and they completed clinical questionnaires, PHQ-9 for depression, as well as a PROMIS anxiety scale, which is part of the NIH toolbox. And there are established cutoffs that help us kind of say, all right, these individuals have enough symptomatology that would put them into more kind of active disease, like they would meet criteria for major depressive disorder based on their symptoms today. And that was our cutoff for responders and non-responders. Responders being low degree of symptoms, non-responders being symptoms at the level that would still meet criteria for diagnosis in that moment or that day. And similarly with anxiety, we used an established cutoff. And what you can see here is that in these two groups, when we dichotomize them into responders and non-responders, there wasn't a difference in brain concentration, plasma concentration, or brain to plasma ratio. And this similar relationship was seen when we looked at symptom scale, or score rather, as a continuous variable. No relationship seen. Well, that might be kind of disappointing, but really I think it's important and useful to help us move forward and know what that next step needs to be. When we think about precision treatment, we often think about exposure as the first place to start, right? And it is often in most cases. And these data help us see that systemic drug exposure doesn't seem to be very informative, our work and others. Brain concentrations, the CNS drug exposure doesn't seem to be as informative. And now, knowing these data, we can move forward to mechanistic factors to say what are other elements, maybe neural response, that can help us provide insight into who might respond and not. And this is some of the work that's ongoing in our lab. Okay, I'm going to shift gears a little bit and talk about the use of 19F to help us untangle the potential for CNS off-target effects. All right, so again, moving away from mental health and speaking specifically about proton pump inhibitors. Proton pump inhibitors, PPIs, they're one of the most commonly used medications worldwide. They are over the counter and or near access is easy to come by in over 100 countries worldwide. And they're used in humans from near birth to older adults, right? Kind of across the lifespan. And they're wildly effective at what they're designed to do, right? They're meant to decrease acid-related consequences, but long-term kind of chronic use was never really the clinical goal, right? And the goal is to use for a period of time to reach remission and then kind of DC as needed. But because access is kind of ubiquitous for these medications, long-term use has become kind of very common for folks. And so there's the potential for complications, and folks have looked at this. There have been pharmacoepidemiologic studies that have looked at long-term use and the incidence of things like dementia and depression. And some studies have shown a pretty convincing relationship and others haven't, right? But again, they're using big databases, they're retrospectively looking back, and they're trying to control for as many confounders as possible. And so when presented with this kind of conflicting set of data, but we have a drug that's widely used and the societal implications of a particular complication could be pretty large, it seems worth untangling a little bit. And when I think about how to do that, I think one of the first questions is what's the biological plausibility of that particular consequence or relationship? If we're talking about the risk of PPIs and dementia in older adults or depression in youth, well, how might that happen, right? Certainly there are mechanisms that have been proposed, like the gut-brain axis, but what about whether or not it gets in the brain? Is that even possible? Does it? Do they get in the brain? And you might be surprised to learn that because these drugs are relatively old and have been around for decades, that data didn't really exist. The level of data that we have and is requested now for approval, as we all know, is very different than it was 30, 40 years ago. And so even going back to animal data, there was one study that looked at pantoprazole and CSF of rats, but we didn't really know what it looked like or if it could get into the human brain. So we were able to kind of look at this with 19F, and we chose pantoprazole. It's got 2 fluorines per molecular structure, per molecule, as you see on the slide. It's highly lipophilic, it's highly protein bound, and it's a substrate for numerous transporters. So it seemed like there were some features here that suggested it might be a reasonable candidate to get into the brain. So we conducted a study in adolescents between the ages of 12 and 21 who were on pantoprazole as part of their clinical care for at least 4 weeks. They had brain scans, peripheral blood sampling similar to the prior study. And this work is still ongoing, but the kind of short takeaway is that yes, it does get in the brain. What you're able to see here in this first spectrum is the the control right here is nice and prominent, but you still see this pantoprazole peak here. We know this is pantoprazole because of its chemical shift, and we kind of the window through which we're looking at detection, as well as through phantoms, which act very similar to kind of your standard curve if you're more familiar with like a mass spec method. So this spectrum is from a 15-year-old male who was on pantoprazole 20 milligrams for several months. And we also have another spectrum from an 18-year-old male on 40 milligrams of pantoprazole. So it gets in the brain. The next step is to understand to what degree or extent. What is the concentration? And we're working on this as well. Then another question is, does it accumulate? If you're on Panto and it gets there, does it exit fairly quickly or does it stay there for a long period of time? And while we're still gathering data to answer this particular question, this is a spectrum from a participant who was off drug for 9 days. And you can clearly see there's no pantoprazole signal here. So perhaps it doesn't accumulate. More to come. And these answers will help us get closer to, is there any concern for kind of meaningful off-target effects, at least from the perspective of a direct effect in the CNS? Okay. So I wanted to move now to talk a little bit about the innovative potential and hopefully sow some seeds of either inspiration or curiosity for this group when thinking about how this might be used more broadly. So we talked about using 19F to detect PK in inaccessible tissues and focus mainly on the brain. But there have been other groups that have used this to detect concentrations in bone, muscle, heart, and liver. The figure you see here is looking at fluvoxamine, which is another SSRI, and trying to identify the anatomical compartment where drug is most likely. So this here is the fluorine spectrum, and you can see that these red areas represent the strongest fluorine signal. And if you superimpose that on other compartments, these are anatomical images, it becomes easy to see that this fluvoxamine is most closely aligned with the bone marrow. And this group looked at that over a period of time, did repeating scans in these individuals, and found that drug was detected in bone marrow for 3 months after it was not detectable in plasma. And so when thinking about whether or not this might be useful for your particular drug or drug program, it is a tool that can help us define tissue elimination and also get a sense of potential off-target effects. And then lastly, when thinking about 19F and other uses, particularly as it relates to maternal and fetal health, it has the option to potentially be used in placental drug disposition. You can see on the image here, this is an anatomical MR image of a fetus and placenta. And there has been MRS studies using other approaches, so proton and phosphorus, to look at things like cell turnover and energy metabolism within the placenta. And this field of view, this white triangle here, that's essentially the area that is kind of focused on. The spectrum is acquired from that particular area within the placenta, and then you're able to quantify the chemicals of interest. And so there are, while this MRS has been done with other atoms, moving on to do it with fluorine is kind of the next step. So key takeaways for 19F MRS, it provides a unique opportunity to detect drug disposition in inaccessible tissues, and it does offer that zero biological background. So if you're detecting fluorine, it's because it was put there, you were taking it, it's not there otherwise. Safe and ethical for vulnerable populations, less than minimal risk as a procedure, and no radiation. Ideally, it's a complementary approach to the other ways we detect PK, right? So looking at drug concentrations in plasma and urine, and so on. And the future potential, I think, is vast. Our group is working on pushing the limits of sensitivity to detect more drugs and detect them at lower concentrations to broaden access and application. And the goal really is see for more effective treatments for kids. So with that, I'd like to thank a large group of folks that contributed to this work. Dr. Phil Lee and Dr. In-Young Choi that you see pictured up on the top right are the MR physicists who developed the 19F method that we used in our studies. I have a wonderful group of research advisors who help make sure we're asking questions that matter to them and staying relevant in the way that we do it, as well as a great lab group here with these folks. So with that, I'll take questions if we have time. Okay, thank you all very much.